So our next speaker is David Dalton, who comes a little closer to home. David also has some Irish connections, although perhaps not quite so ingrained, I think, on your father's side, I think you mentioned earlier. And David is currently the CEO of Salford Royal NHS Foundation Trust, and he's almost unique, I think, in the UK in that he's been in that post for the last 11 years. As many of you will know, within the UK, there seems to be quite a rapid movement of CEOs between trusts. But certainly, I think a bit like Alex Ferguson from Manchester also, he seems to have outstayed a lot of its contemporaries. So David has a particular interest in improving patient safety and the quality of patient experience. And interestingly, he chairs a network organisation of highly performing NHS Foundation trusts called NHS Quest. So we're looking forward very much to hearing David's presentation.
Well, thank you very much indeed for the introduction, and like Stephen, I want to thank Philip and others for the hospitality last night. And as you heard, almost 12 years at Salford now, and I can assure you that every mistake there is mine, and nobody else's. That's one of the things that does happen if you're a chief executive and you stay for that period of time. You know, all the graffiti around the hospital that they've written about you is absolutely true. So let me start by just flashing this up. You can read the words there if you wish to, but it can't have escaped you in this country that we received a report from Robert Francis, who looked into standards of care at one of our hospitals in mid-Staffordshire. And I have to say the report is very long. This is the second volume. But it really makes you feel ashamed of the English healthcare system when you read what happened at Mid Staffordshire Hospital. This is when an organisation put its own interests ahead of its patients' interest and ignored all the signs and signals that you would expect, not only in the data, but in what was being said to them by patients and by relatives. And we have a lot of learning to do in England as a consequence of this report. But what I would say is some of what Robert Francis revealed and what the relatives feel so strongly about is taking place right now in your hospital and in my hospital. None of us can think that we run organisations where there aren't events happening that we would not wish to see happen. So I think we all have to be mindful in whichever system we work in, whichever country, these things happen. And we must always be on the lookout for harmful events and the antecedents of those, the culture that can take place and can grip an organisation. Let me tell you something about me and the journey that I've been on. So, yes, nearly 12 years in Salford, and I've always been somebody in administration and management, and thought that I ran reasonably good hospitals, including the one that I'm in at the moment. The top left there is just a depiction of me, really, just how I felt when I went over to be a sponsor of a speech therapist who became a fellow at the Institute for Healthcare Improvement in Boston. I went for the wrong reasons. I went to go and explore the city, but I also took time to sit in on a few of the meetings. And I have to tell you, I heard things that I didn't know anything about. I sat there thinking, I can't really get involved in the conversation here. And at the time, we were talking about standardised mortality rates, and England wasn't talking about those at all. We were talking about the global trigger tool being used as a method of surveillance of harm. I didn't know about this at all. I was hearing all about harmful events and also hearing from people that you could do something about them. And I have to say, over a matter of weeks, and it was just a few weeks, I decided that I had misunderstood my role as a chief executive of a hospital and committed myself to do something about it. And we, rather naively, produced a strategy which was that we would be, or certainly have an ambition to be the safest organisation in our National Health Service, and that we would save over the course of 3 years 1,000 lives, and we would reduce harmful events by half. And that's what happened. I went into the TV studios and said, do you know what? Salford Royal harms 850 patients a month, 10,000 patients a year. And I'm the chief executive and I'm responsible for that. But I'm going to do something about it. And it gripped my organisation and the rest of the National Health Service to hear that. And we've gone through iterations, and I'm now a little more aware of what it is that I'm embarking on. I still see myself very much a novice and a learner in terms of our improvement activity. I just want to play. I think these slides, just 4 of them, play through every few seconds here. And I don't know, I'm sure many of you in the audience have seen pressure ulcers, and you know that when we talk about reductions, we're not talking about just numbers here. We're talking about real people who experience something as a consequence of what we have done or haven't done. And I think that when you see this, you can really see what it is that you have a responsibility for, and I do too. Those photographs were taken in my hospital. They're patients that I had a responsibility for, and the systems that we were operating at the time failed them. Those pressure ulcers should never, ever have happened. Now, in England, we have a population of 63 million. But in our hospital systems, we have now a surveillance system which records how many pressure ulcers are experienced by patients. And anybody want to hazard a guess and just shout out a number? In a year, how many pressure ulcers do you think we record in England? Certainly it's going to be a lot, isn't it? It's 187,000 pressure ulcers. And the view is that just short of 150,000 of those are avoidable. And that information was from last year. So, let me start by just saying Robert Francis was very clear that the responsibility is the board's responsibility. How many here are leaders from a board in the audience? Just raise your hand so I can get a sense. A few. Well, you should know the responsibility that you have, and I hope that you recognise that your system is perfectly designed to deliver what it delivers. Salford Royal, 6 years ago, was perfectly designed to harm 10,000 patients a year. And I think if you think in that way, you start to realise that the board really has to take that responsibility very seriously. And when it's looking at its improvement, frames it in terms of what is going to improve, how much and by when. And the board has to say that and really believe that they are going to make a difference in changing what it is that they want to see improvement on. And as I said, we had this ambition to be the safest organisation in the NHS as measured by mortality and what we in our country use, the safety thermometer, to measure harm. And I can tell you we now have the 5th lowest mortality rate in the country, so we still have some way to go. And the harms that we measure, I'll tell you about in a moment. Now, like Stephen, I'm attracted to the notion of high reliability. It's interesting, we've never spoken on the platform before, but you'll see these words repeated here about the importance of components in whichever industry you examine that have this core tenet of high reliability. Now, this is probably not the most fetching photograph of me, but in the top left. But one of the things that we do, and I've seen that you do as well, is have your safety walkarounds. That you expect your leadership to be present on your wards and departments. And I do this at least once, and most occasions twice a month. I spend half a day working alongside staff, becoming aware of what they're doing. And I'm going to talk very quickly about some of these other issues too. So I love this term, the currency of leadership is what leaders pay attention to. And if I said that patient safety is the most important issue for me and my board, but then when I went onto the ward, I was talking about the financial situation and what we could do to save money or the waiting times, then people would sort of pretty soon get that I wasn't authentic. I didn't really believe in this. I was just saying it because somebody suggested that I ought to. So really important, I think, that your leadership, what you expect from people like me, is that authenticity, and that they are interested, genuinely interested in what people have to say when they visit the ward or the department. And it's reinforcing the breaking down of the barriers that can exist between clinical staff or staff generally and the management of the organisation. Now, often we try and seek simple solutions to complex problems, and that is human nature. My advice to you, if you're on this journey like I am, is to really recognise that you can get to the wrong place if you try and simplify the complexity too soon. So just flashed up here, not intended for you to get in and read all the words there, but you are going to have some method. You are going to have some process of breaking down that complexity to really understand what it is that you're attempting to improve. We use driver diagrams, we use the Breakthrough Series Collaborative, the model for improvement of learning collaboratives, and we're constantly checking our information sources. And I want to just mention measurement and the importance of it. I mean, we all get dashboard data presented to boards, but I wonder how many boards really understand the data that's being presented to them. Normally it's red, amber and green. Is that how you present a lot of your information? There's nothing wrong with that really, but it's not telling you a great deal. It's, if you're seeing information at a single point in time, it's not really giving you what you should be looking at. And I'm sure that if you want to understand the prevalence of pressure ulcers in your organisation, let's say, you can go to a number of places. You can do a bedside audit. You can do a case note review. You can take information from your information system, coded information. It will tell you how many pressure ulcers are in your organisation, but I guarantee that that dependent upon the source of your data, you'll be getting different results. And I don't think boards understand this as well as they might. And one of the most important things we've realised is that we have to get our senior management and clinical staff familiar with measurement and looking at the use of statistical process control charting. It ought to be, every one of our leaders, whether they're clinical or managerial, ought to be able to read a statistical process control chart in the same way as they can read their budgeted financial information. And they ought to understand the noise that exists in the system and when they have special cause variation. And I think that the power of measurement for improvement is something that's often overlooked, and I would urge anybody in this audience who really wants to make a difference in their organisation, to think about what you measure. And in the past, we've measured different silos of harm. So how many pressure ulcers, how many falls, urine infections, whatever it might be. And we're very proud of the numbers that we produce to look at how many pressure ulcers there might be counted against how many patients we've seen. And yet, I think this is the wrong way round, don't you? Measuring individual harms takes you so far. I think so much better to be presenting the information in terms of the patient's experience. What I want to know is how many patients in my hospital experienced harm-free care, not how many pressure ulcers we had and we've seen a 10% reduction. I want to know just how many patients had harm-free care by looking across to count that, rather than to count just individual harms that may occur. And the final issue in terms of the way that we organise our quality improvement with a focus on patient safety is really to understand that the ideas for improvement are going to come from deep within the organisation. How arrogant of me to think that I know what it is that people ought to be improving on their wards or in their departments. This really has to come from an understanding that the microsystems that impede our staff from providing the highest standards of care, those are going to be understood by the people who are in daily contact with them, and not by somebody like me. So similar to Stephen's story, we use a process of getting people to focus on an improvement issue, bringing people from across the organisation into learning collaboratives, getting them to think about what it is that we want to improve. And this is similar to Stephen's story, looking at eliminating cardiac arrest calls within our hospital. And the ideas didn't come from me. The ideas came from the staff. We showed them how they could test their ideas. We showed them how to measure to see whether the change in practice was leading to an improvement or not. And then, when the moment was right, when we tested this in enough places in the hospital, we reset the system completely based upon those improvement ideas of our staff. And we now have a situation where we have less than 10 cardiac arrest calls in the whole of our 850 bedded hospital, and previously we were receiving 130 cardiac arrest calls, now down to less than 10, and all done on the basis of what our staff were testing and measuring. We've invested a lot of money in quality improvement. The first time we became what's known as a foundation trust in England, we were allowed to keep our surplus, the money that we saved, and I decided I was going to spend it on quality improvement, and I was going to spend it on developing our staff and their capability to be improvers. So this is just some numbers here about who's experienced our improvement activity or our development capability. Now, we employ 6,500 people, and you'll see we're not even halfway, but we're getting there. So about half of our staff have experienced being on one of our learning collaboratives, and that's great. We are building the capability deep inside the organisation for people to be testing their ideas out. I just want to say very quickly one thing that I attach huge importance to, and that is getting alignment between staff and the key plans of an organisation. Now, I spend time writing our annual plan and our strategy, but I really shouldn't be surprised that 2 layers into the organisation, nobody gives a monkeys about them at all. And yet they are important. The board is setting out what it wants to do, and particularly setting out what it wants to do around patient safety. And I think that we have to get this alignment between an individual's contribution to the priorities of the organisation. And we're spending a lot of time in thinking this through about how we focus the effort and also the discretionary effort of our staff towards our key goals. Now, I have a view, and I don't know what it's like in this country, but we have some excellent organisations and some poor ones. We have some brilliant doctors, nurses, professional staff, chief executives. We have some poor doctors, nurses, professional staff and chief executives. We have normal distribution in most of the things that we look at. And the problem is in the English health system, we tolerate the excellent and we tolerate the poor, and we do nothing about either. And what I think that does is reinforce mediocrity. And I think that's true about our own staff. We have some brilliant people and we have some who really aren't pulling their weight in the team. And how do we do something about that? How do we avoid just reinforcing mediocrity? And that's the issue my board is looking at the moment, of trying to think this through with them in looking at the values and the behaviours that we expect and measuring those. I'm part of this. Every one of our clinical staff are part of this, and seeking through proper methods of assessment a description of where they feature in terms of their contribution. Now, this is controversial, and we are determining people's pay on the basis of an assessment of their contribution to the organisation. We have discretionary pay that we give to our consultant medical staff, and it's based upon this assessment as well. But I think without it, I don't know how you really get people's commitment to follow through on what you're attaching importance to. And if it is patient safety, how do you get that alignment between what the board is saying is important and what people are actually doing? So we have also developed our nursing assessment and accreditation system. It measures 13 standards on our wards. Those wards are visited every 2 months, and there is an assessment. We have 4 levels of status, of rating, if you like. And our red wards are our worst wards, and our blue wards, we call it SCAPE, that's safe, clean and personal every time. Those are our best wards. And this is something that our nursing staff have really got into, because they know those standards, they know what's expected of them, and they want to be able to demonstrate improvement. We now publish this on a board. As soon as you go through the door of our ward, our patients and the relatives know the status of that ward. We will publish if it's a red ward or a SCAPE, a blue ward. We also put on there how many days since the last infection, how many days since the last fall, and we are about to publish our staffing levels and state each month whether we have been able to achieve the levels of staffing which we think are appropriate for patient safety. I should just say that those wards where they achieve the highest status, we upgrade the ward sister, who becomes a matron, and we provide a little bit more money for personal development, for training and development of staff. And I have to say, those wards where we haven't got the improvement, our red-rated wards, often a product of leadership, that the wrong person is in the wrong place at the wrong time. And sensitively, we have moved the ward sisters into other roles and replaced the leadership on those wards. So creating a system of consequence, I think, is really important. I just want, in my final couple of slides, just want to talk about this notion of culture and teamwork. You may have seen this slide. You probably know about the Matching Michigan work that was taking place, looking at outcomes in a number of critical care units in America. I like this slide because what this tells me is there is correlation. You can see on the different axes there, those organisations that were reporting no bloodstream infections. And interestingly, those organisations that were reporting a high level of teamwork that was existing within those intensive care units. And you can see there is correlation. Those units that were saying, I'm working in an intensive care unit where teamwork is strong, I feel that this is a good place, also were showing the lowest levels of bloodstream infection. And so last night I heard that you are introducing, or I don't know yet whether it's happened, Philip, but you're introducing a safety attitude survey into your organisations, and I think this is tremendous, and I commend you in doing that, because just a little bit of propaganda about my organisation and what we've been able to achieve over the last few years. But look over there far right. We have consecutively, in our National Health Service, a staff satisfaction survey. A third of the staff are randomly selected. They fill a form. It doesn't matter which hospital you work in, and that's reported publicly. And 3 consecutive years, my hospital's had the highest rating in that staff satisfaction survey across the whole country. Now, I say that not, well, maybe I do say it to seek some reaction and to be impressionable to you. But what I want to say is really associated with the next slide, because this isn't about me being having a misplaced sense of pride or arrogance, because we also use our survey tool to have a look at the attitude of our staff. So recognise that we do have a pretty good morale in our hospital, and have done for a number of years. This is taken from the survey that was done just over a year ago, looking at the climate for teamwork, what people were saying about what it felt like in their individual ward and department, and you'll see that we use a company called Pascal Metrics, who I rate very highly, and they've put the line where they think the danger zone lies, according to their years of experience, where they think that because of the reported sense of poor sense of teamwork within a number of our wards, they would say you're really at the danger zone where unsafe practice is going to happen, where people don't feel they're able to speak out and talk about some of the things that happen on that ward. So even amongst an English hospital with the best staff satisfaction, when you drill right down and you get into asking questions of individual members of staff, what's it feel like working on this ward, it reveals this sort of data. And this is where as a chief executive, this is where I want to go to. I don't want to just aggregate all my data up and present it in an average way. We have to do that. We have to report as a whole organisation. I'm much more interested. I don't want to have the camouflage. I want to know which wards I have to go to and have conversation with, where there may be the culture of unsafe practice. So if you are embarking on doing something similar in your organisation, then do remember to get that granularity rather than just look at what's happening across a whole hospital. So my final slide returns me back to Robert Francis and the messages that he was putting out there, particularly for the English health service, but I think for all health services in the world. But we're going to be likely to be doing some things differently. We will be stating what our fundamental standards of care are, what a patient can reasonably expect, and we will be taking, through the employment of a chief inspector of hospitals, be able to rate every single hospital, all 220 of them in the country, and report back to the public about the standards that are taking place there. We'll be setting up quality surveillance groups which take the soft information, the newspaper cuttings, what people are talking about that hospital, and putting it alongside the hard data of mortality and harm as well. I come on many stages and talk about giving information to the public, and it was great to hear your health minister talk about that as well. This notion of being open and transparent and publicly reporting is what every healthcare organisation must do. Don't be ashamed of it. Go with it. You're not perfect. None of us are, but far better that you've got that culture of reporting openly to the people who use your services. And right there, an echo to what Stephen was saying about the importance of becoming a highly reliable organisation. And let's hope that Robert Francis and his report really does signal that every organisation will put the patient's interests ahead of their own organisational interests. Thank you very much. Thank you.